Ever had a headache so intense, so sudden, it felt like, well, like lightning striking inside your head?
Yeah, that's a pretty dramatic description, but honestly not far off for some people.
We're diving into subarachnoid hemorrhage today, SAH for short. It's a condition that often makes its entrance with exactly that kind of uh, terrifying headache.
Exactly. And we've got a good set of revision notes here. Our plan is basically to break down this pretty complex topic into the absolute essentials you need to know.
Think of this as your, let's say, fast track to getting a handle on SAH. We'll cover the definition, what causes it, the risk factors, how it actually affects the brain.
What else might look similar? Who tends to get it? The clinical signs, how it presents.
Right, and then how it's diagnosed, the treatments, what happens next, and importantly, the potential problems or complications.
And we'll try to sprinkle in some memory tips along the way, things to help make it stick for your revision.
Sounds good. So let's jump right in. What exactly is a subarachnoid hemorrhage?
Okay, so, put simply, subarachnoid hemorrhage, or SAH, is bleeding into the subarachnoid space.
And that space is...
It's the area between the brain surface itself and the sort of inner layers of its protective coverings, the meninges. It's normally filled with cerebrospinal fluid, CSF.
Gotcha. And what usually causes this bleeding?
The most common cause, by far, is a ruptured intracranial aneurysm. That's like a weak spot, a bulge in a blood vessel wall inside the brain that just bursts.
Like a little balloon popping.
Yeah,
But you said most common, so are there other causes? The notes mentioned a few things.
that's right. While a ruptured aneurysm is number one, SAH can also happen because of trauma, a serious head injury, for instance. That's actually the most common cause of traumatic SAH.
Okay, trauma makes sense. What else?
Well, other possibilities, though less frequent, include things like vascular malformations, AVMs, arteriovenous malformations are one type, basically tangled blood vessels. Then there's vasculitis, which is inflammation of the blood vessels, or arterial dissection, a tear in the artery wall. Even things like venous thrombosis, tumors, or sometimes drug abuse, like cocaine, can trigger it.
And it's worth distinguishing this from aneurysms that haven't ruptured, right?
Absolutely. An unruptured aneurysm might cause no symptoms at all, or it could cause different issues, maybe seizures or neurological problems if it presses on things. It's the rupture that causes the SAH bleed.
Okay, that clears up the definition. Now, let's focus a bit more on the causes, the etiology. You mentioned ruptured aneurysm is the main one for spontaneous SAH.
Yes, definitely the most frequent culprit for spontaneous non-traumatic SAH, but we should list the others again for clarity.
Good idea.
So besides aneurysms, we have those AVMs we mentioned, pituitary apoplexy, that's a sudden bleed or lack of blood flow into the pituitary gland. Arterial dissection, again.
Okay.
Then mycotic aneurysms. These are aneurysms caused by an infection weakening the vessel wall. And something called paramesencephalic hemorrhage.
Paramesencephalic, what's that?
It's often thought to be a bleed from a vein near the midbrain, sort of idiopathic, meaning we don't always find a specific cause. But the good news is it generally has a better prognosis than aneurysmal SAH.
Interesting. And just to reiterate, for traumatic SAH, head injury is the main driver.
That's correct.
So we know the causes. Now, who's more likely to experience this? What factors put someone at higher risk?
There are several well-known risk factors. High blood pressure, hypertension is a really big one. Smoking is another major player.
No, lifestyle factors.
Definitely. Then there's family history. If you have close relatives who've had an SAH or a cerebral aneurysm, your risk is higher.
Makes sense. Any specific conditions?
Yes, certain connective tissue disorders like Ehlers-Danlos syndrome seem to increase risk. Polycystic kidney disease is another association. And as we touched on earlier, stimulant use, specifically cocaine or amphetamines, is a significant risk factor. Age plays a role too. It's most common between 40 and 60. And it's slightly more common in women than men.
That's quite a list. The notes also mentioned an overlap with general stroke risk factors.
Yeah, that's a key point. Things like hypertension and smoking, they're risk factors for strokes in general, not just SAH. And it stands to reason, really, that larger aneurysms are more likely to rupture, more pressure on that weakened wall.
Right.
It's also worth knowing that most berry aneurysms, they're called that because they look like little berries, are initially quite small, maybe less than 7 millimeters, but they can grow, sometimes unpredictably. Especially the ones located in the circle of Willis.
The circle of Willis. That's that crucial network of arteries at the base of the brain.
Exactly. Vital for blood supply. A common spot for these aneurysms to form.
Okay, so we've got the who and the why. Let's dig into the how. What actually happens in the body when one of these aneurysms bursts? the pathophysiology.
Right. So the first event is the rupture itself. Blood suddenly floods into that subarachnoid space, which, remember, is normally just filled with CSF.
And blood shouldn't be there.
Exactly. The blood is incredibly irritating to the meninges, those brain coverings, so you get inflammation. At the same time, you've got this extra volume of blood crammed into a fixed space, the skull,
So pressure goes up?
dramatically. Intracranial pressure skyrockets. And then a really dangerous potential complication kicks in, often a few days later. Vasospasm.
Vasospasm. The blood vessels clamp down.
Precisely. The arteries in the brain constrict, which reduces blood flow even further, potentially starving parts of the brain of oxygen. That's called ischemia.
So it's a cascade of problems.
It really is. The initial bleed, the inflammation, the high pressure, then potentially vasospasm. It all leads to brain tissue damage, disrupted blood flow, neurological problems, and yeah, it can absolutely be life-threatening.
A very dangerous chain reaction indeed. Now let's switch gears slightly. If someone presents with these symptoms, especially that worst headache ever, what else could be going on? What's the differential diagnosis?
That's crucial because that thunderclap headache is alarming. But it's not only caused by SAH. We absolutely have to rule out other things quickly.
Like what? Other headaches?
Yeah, severe migraines can sometimes present very suddenly. Tension headaches, cluster headaches, although they usually have different patterns. But more seriously, we need to think about other neurological emergencies.
Such as?
Intracerebral hemorrhage that's bleeding into the brain tissue itself, not just around it. Ischemic stroke, where a clot blocks an artery. And meningitis infection of the meninges can cause severe headache and neck stiffness, mimicking some SAH signs.
Okay, those are the big ones. The notes had quite a long list, though.
They did. The differential for a thunderclap headache is broad. You also need to consider secondary headaches triggered by things like coughing, sex, or intense physical exertion.
Right.
Other kinds of stroke need to be considered. Trauma, even if the patient doesn't initially report a significant injury. Cerebral venous sinus thrombosis, a clot in the veins draining the brain. Dissections of the big arteries in the neck, the carotid and vertebral arteries, can cause sudden severe head or neck pain, a hypertensive emergency, just dangerously high blood pressure itself, and that pituitary apoplexy we mentioned earlier.
Wow, okay. It really highlights why you need a thorough workup. Let's talk numbers then. How common is SAH? Who does it typically affect, statistically? Epidemiology.
Right, the numbers. SAH happens to about 6 people per 100,000 each year. It's not super common, but the outcomes can be severe.
Yeah, you mentioned high mortality.
Very high. Around 30% die within the first 24 hours. Overall mortality is about 45%. It mainly affects adults, usually between 40 and 70 years old.
And you said slightly more common in women.
Yeah, about 1.3 times more likely in women. The average age it hits is around 50. Spontaneous SAH from aneurysms causes about 5% of all strokes, but it's responsible for the vast majority, like 85% of all spontaneous SAH.
Interesting stats. Any differences based on ethnicity or location?
Yes, there's a higher incidence noted in people of Afro-Caribbean descent, and also in certain countries, like Finland and Japan, for instance. And just to circle back to trauma, SAH is seen in up to 60% of traumatic brain injuries.
Those figures really drive home the seriousness. Okay, so clinically, apart from that awful thunderclap headache, what other signs and symptoms should make you think of SAH?
Well, the headache is key. Sudden, severe, often occipital, meaning at the back of the head. Reaching peak intensity almost instantly. That's the classic thunderclap. But beyond that,
Yes.
neck stiffness or pain is very common. That's the meningeal irritation. Nausea and vomiting often accompany the headache. Altered consciousness is a big one, anything from slight confusion right through to coma. Seizures can happen at the onset or later, photophobia being really sensitive to light. Some people have a brief loss of consciousness right when the headache hits, and you might see specific neurological deficits, like weakness down one side, depending on where the bleed is.
The notes also mention something called sentinel headaches. What's that about?
Ah, yes. Sentinel headaches are like warning shots. Smaller leaks from the aneurysm that cause sudden, severe headaches days or weeks before the major rupture.
So they might be missed.
Easily missed or dismissed as just a bad migraine. But recognizing them could, in theory, allow for intervention before the big bleed happens. It's tricky, though.
And what might you find on examination?
Well, you'd assess their level of consciousness using something like the Glasgow Coma Scale. Look for those neurological signs we mentioned: weakness, speech problems. Check the pupils if they're dilated and don't react well to light. That can suggest very high pressure, possibly brain herniation, which is extremely serious.
Anything else?
An eye exam with an ophthalmoscope might show bleeding behind the retina subhyaloid hemorrhages. And remember, hypertension is a risk factor, so their blood pressure might be sky high during the event itself.
A really alarming clinical picture. So if someone presents like this, suspicion is high. What's the absolute first investigation? What do you need to do right away?
The number one immediate investigation is a non-contrast CT scan of the head.
Why non-contrast?
Because acute blood shows up bright white on a non-contrast CT, making it relatively easy to spot in the subarachnoid spaces, those basal cisterns, sulci, maybe in the ventricles. Contrast could obscure that.
How reliable is this CT?
It's very good, especially if done soon after the headache starts, ideally within 6 hours, but it's not perfect. It can miss maybe around 7% of SAHs, especially if the bleed is small or some time has passed.
Okay, so what if the CT is negative, but you're still really suspicious?
Then the next step is usually a lumbar puncture, an LP or spinal tap.
And what are you looking for in the spinal fluid?
We're looking for evidence of blood breakdown products, specifically xanthochromia.
Xanthochromia.
It's a yellowish discoloration of the cerebrospinal fluid, the CSF. It's caused by bilirubin, which is produced when red blood cells break down. If there's been bleeding into the CSF, bilirubin will form after some hours.
So the timing of the LP matters.
Critically important. You need to wait at least 12 hours after the headache started for xanthochromia to develop reliably. Doing it too early can give a false negative. The LP also lets you measure the opening pressure, which is often high in SAH.
And if either the CT or the LP confirms SAH?
Immediate referral to neurosurgery, absolutely urgent, no delay.
Got it. Then, once SAH is confirmed, how do you find the source of the bleed, usually the aneurysm?
The main tool for that is a CT intracranial angiogram, or CTA. This uses contrast dye injected into a vein, and the CT scanner takes detailed pictures of the brain's arteries. It's pretty good at finding aneurysms and AVMs.
Pretty good. What if it doesn't show anything or it's unclear?
In some cases, particularly if the CTA is negative but suspicion for an aneurysm remains high, the next step might be a digital subtraction angiogram, a DSA.
How does that work?
It's more invasive. A catheter is threaded up through an artery, usually in the groin, right into the neck arteries feeding the brain. Contrast dye is injected directly, and special X-ray techniques subtract out the bone images, giving really clear pictures of just the blood vessels. It's considered the gold standard, but carries slightly more risk than CTA.
Okay, so CT first, maybe LP if needed, then CTA or DSA to find the cause. You mentioned timing for the initial CT and LP.
Right, just to recap that. Ideally, initial CT head within 6 hours of onset. If that's negative, clinical judgment guides next steps, maybe consider alternatives, or wait. If the CT is done after 6 hours and is negative, then an LP after 12 hours from onset is generally recommended to look for that xanthochromia.
And xanthochromia is detected how?
In the lab, using spectrophotometry. It basically measures how much light of specific wavelengths is absorbed by the CSF sample, which can quantify the amount of bilirubin and related pigments present.
Right, very precise.
Yeah.
Okay, so we've got the diagnosis. We hopefully know the cause. How is SAH managed? What's the treatment?
The first thing is immediate stabilization. ABCs, airway, breathing, circulation. Make sure they have a clear airway, give oxygen if needed, get IV access, monitor their vital signs continuously, heart rate, blood pressure, oxygen levels.
Then medications.
A crucial early medication is nimodipine. It's a calcium channel blocker, and the key thing it does is help prevent or reduce the severity of that delayed vasospasm we talked about. Everyone with aneurysmal SAH generally gets nimodipine for about 21 days.
Okay, nimodipine for vasospasm. What about fixing the aneurysm itself?
That's the definitive treatment. You need to secure the aneurysm to prevent it from bleeding again. There are two main ways to do this.
Which are?
Surgical clipping or endovascular coiling. Clipping involves open brain surgery. A neurosurgeon places a tiny metal clip across the neck of the aneurysm, sealing it off from the artery.
And coiling?
Coiling is done via angiography, similar to the DSA. A neuroradiologist guides a catheter up into the brain aneurysm and packs it tightly with tiny, soft platinum coils. These coils cause the blood inside the aneurysm to clot, effectively blocking it off from the inside.
How do you decide between clipping and coiling?
It's a complex decision. Depends on the aneurysm's size, shape, and location, the patient's overall condition, whether the aneurysm has ruptured or not, and local expertise. Often, a multidisciplinary team makes the call.
What about other complications, like hydrocephalus, that fluid buildup?
Yeah, that needs managing. If the CSF pathways are blocked by blood, pressure builds up. This might require an external ventricular drain, or EVD, a temporary tube placed into the brain's ventricles to drain excess fluid. Sometimes a permanent shunt is needed later on.
And general care.
Absolutely vital. Strict bed rest initially. Careful blood pressure control. You don't want it too high to risk rebleeding, but not too low either, as that could worsen brain ischemia. Pain relief. Stool softeners to avoid straining, basically keeping the patient calm and stable.
And after the acute phase?
Rehabilitation is often crucial. Physiotherapy, occupational therapy, speech therapy if needed. Follow-up neuroimaging is usually done to check the aneurysm treatment and monitor for complications.
What if they found other unruptured aneurysms during the workup?
That needs careful consideration. Treating these incidental aneurysms depends on their individual risk of rupture versus the risks of treatment. Sometimes they're treated proactively, sometimes monitored with regular scans.
And long-term management after discharge.
Managing ongoing issues is key. Controlling blood pressure, definitely stopping smoking, managing any persistent headaches or seizures if they develop, maybe antiplatelet drugs depending on the treatment used.
You mentioned family history as a risk factor.
Yeah.
Should relatives get screened?
That's a common question. Generally, routine screening for asymptomatic relatives isn't recommended unless there's a strong family history, usually defined as having 2 or more first-degree relatives, parents, siblings, children, who've had an aneurysmal SAH. Even then, the benefits versus risks of screening need careful discussion.
Okay, a really comprehensive approach needed. What about the outlook? What's the typical prognosis after an SAH?
Prognosis is highly variable. It really depends heavily on how severe the initial bleed was, the patient's age and prior health, and whether they develop complications like vasospasm or rebleeding.
But early treatment helps.
Absolutely. Getting diagnosed and treated quickly is critical for improving the chances of a good outcome. But even with the best care, SAH remains incredibly serious. Mortality is still significant.
What were those figures again?
Over 25% mortality within 6 months. And remember, 10–15% die before even getting to hospital. But for those who are admitted with a confirmed aneurysm and get treatment, survival is around 85%.
Survival, but not necessarily full recovery.
Exactly. Rebleeding is a major killer, especially if the aneurysm isn't secured quickly. The risk is highest early on, maybe 15% risk on day 1, rising to 40% within a month if untreated.
And the long-term effects for survivors.
Significant disability is common. Estimates vary, but maybe 10–20% of all SAH patients, or perhaps 17–46% of survivors, end up dependent on others for daily activities. Cognitive problems are also very frequent memory issues, difficulty concentrating. Nearly half of survivors report incomplete cognitive recovery a year later.
So substantial long-term challenges are possible. Let's list those complications again, just to be clear. What are the main things that can go wrong after an SAH?
Okay, key complications. Number 1, rebleeding. Highest risk early on, very high mortality if it happens.
Right.
Number 2, vasospasm leading to delayed cerebral ischemia. Typically happens about a week or so after the initial bleed, causing stroke-like symptoms.
Okay.
Number 3, hydrocephalus, that fluid buildup requiring drainage or a shunt. Number 4, seizures.
Seizures, okay.
Number 5, other stroke mechanisms, maybe related to the procedures or underlying vessel disease. Number 6, cognitive deficits, as we just discussed. And sadly, number 7, death.
You stressed how dangerous rebleeding is?
Yeah, it happens in about 10% of cases, often within 12 hours. Mortality can be up to 70%. It's why securing the aneurysm quickly is paramount.
And vasospasm.
A major cause of poor outcomes in those who survive the initial bleed. That's why pneumotapine is so important and why patients are monitored closely for any neurological worsening in that 7–14 day window.
Any other common issues?
Hyponatremia, low sodium levels, is quite common, maybe due to SIADH or something called cerebral salt wasting. Can cause confusion or seizure if severe.
Good.
You can also get other bleeds like intracerebral or subdural hematomas or brain swelling, cerebral edema. Hydrocephalus requiring intervention happens in maybe 30% of cases. Epilepsy after discharge affects 5% or more.
Wow, even cardiac issues.
Surprisingly common. The stress of the SAH releases a flood of catecholamines, which can stun the heart muscle, cause ECG changes seen in over 90% of patients, or arrhythmias. This can lead to low blood pressure, which is bad for the brain if it's already struggling with vasospasm.
And electrolyte problems beyond sodium.
Yeah, hyponatremia is the most common, seen in about 30%, but other disturbances can occur too. Managing fluids and electrolytes carefully is a big part of the intensive care management.
It really highlights just how much can go wrong systemically, not just in the brain. Okay, as we wrap up this deep dive, what's the single most important thing you want our listeners, especially those revising, to take away about SAH?
I think the key message is SAH is a time-critical neurological emergency. Recognizing that sudden, severe thunderclap headache is vital. Understanding it's usually caused by a ruptured aneurysm, knowing the risk factors, the key investigations like CT and LP, the main treatments like coiling or clipping, and being aware of those major complications like rebleeding and vasospasm, that's the core knowledge you need.
Absolutely. Prompt recognition, rapid investigation, and urgent specialist management are crucial. It's a stark reminder of how vulnerable our brains are, isn't it?
It really is.
For everyone listening, if you want to consolidate this and test yourself, definitely check out PassMSRA.com. And there are also great free resources and questions over at freemsra.com. They're excellent for getting this kind of critical information locked in for your exams.
Yeah, great resources for revision.
What